Yeah, so education in its own right has been found to be useful in managing chronic pain. In other words, as an intervention tool, and it only makes sense. If a person had diabetes, we would send them along to the diabetes day and they'd learn all about diabetes and what to eat and how to exercise. We don't do it for chronic pain, except in Burwood we do now. And so that's one aspect of it. But two, what we found is that people really haven't had their pain experience validated. And by spending a day and educating them about it, they then come to understand what it's about. It's not just all in their heads. And so that's enormously powerful as well.
Okay. Just to outline what we keep referring to at Burwood, we do a pain education seminar, and we've been running that for almost 2 years now. The seminar is called BASE, which stands for the Burwood Advancement Screening Education Seminar. Pretty long-winded. But what it is it's a full day education. The morning covers the neurobiology of pain and validation of pain. And then the afternoon covers self-management principles that help people to live with pain. And when our patients leave, they leave with a plan going forward of what they could be doing to manage their pain a little bit differently. And so we have a physio come in, a psychologist come in, an OT come in, a nurse come in, and medical input as well. And we use it as education, and it's very helpful for our patients, but we also use it as a triage tool because it helps us see who wants to come to our service. The people we invite to come to the seminar that don't turn up, we're probably never going to turn up or engage, so it's a good way of kind of figuring out who's actually open to self-management and who wants to get that surgery at Christchurch Hospital, the other hospital in Christchurch. And then at the end of the education seminar, we actually get people to write down what they think they need next. And that's pretty novel in a health system because usually we have our referral information from GPs or from surgeons or other people. And we have our clinical opinion about what people might need, but we don't have the patient perspective. And so we find it really valuable, don't we? A really important number, 1 in 5, because it affects a lot of people, and if it doesn't affect a person, chances are it affects someone that you know or a relative or something like that. But what we also know is that it doesn't affect everyone in the same way. So you'll have some patients with chronic pain who are highly disabled and distressed by their pain, and others, how do we make the light go here, guys? Others are much more low need. So we have people running marathons, people working full-time jobs, people doing all sorts of miraculous things while they're still in chronic pain. So I guess what we're talking about then is targeting this group of people and maybe helping this group of people not to become so complex or so disabled and suffer so much with their pain. Because you can't see pain. And so like those scans, you can look at a scan and you can, particularly for our patients where they have a scan and nothing shows up, it's really problematic. You can't see pain on a scan, you can see pathology, but if you look at this picture, either of these kids, in our service we see kids right down to about 9 with chronic pain, or even if we look at these adults, who's in pain? Which one is in pain? Or which people are in pain? You just don't know. And the problem with that is, for people who do have chronic pain, they feel like people don't understand. They feel like they have these tests, they come back clear. People start to kind of question their symptoms, start to feel like people might not believe them, or that they're exaggerating, or that they're malingering, or those kinds of words come up all the time. And when Ian and I stand up and do education and I say I'm a psychologist, then they really think that because they think, now they're going to get tested to see if they really have pain. And so education is incredibly important because what it does is it starts to help people to understand what is going on in their body, and it gives them a sense that people really believe them, that there is actually a problem, that there is actually something going wrong in their body. Do you want to talk to this slide, Ian?
Yeah, there was a recent study, and John's our study reference person, he can quote all the studies in the world, in America, where they looked at lower socioeconomic group, and people that had a very low average education, and they did a pain education course, and obviously explaining things in ways that were understandable, and they had benefit from it. And so it can be applied across the sectors, really.
Some of the slides that we've shown already today, the guy with the nail through his foot and the guy with the nail in his head, we use those exact slides with our patients who come to base. And the slides coming up where we educate around the differences between acute and chronic, we use those slides as well with our patients. So you'll see today what we use. And some of it's quite complex information, but it's delivered in a way that we hope patients really understand. A common message we get when people come to our seminar is, I didn't want to come today, but I'm really glad I did. Because I think that comes back to expectation management. So we've been doing a lot of education with GPs in our area to help them set expectations to their patients about what they should expect from base. But I still think there's a lot of people that come along and they're expecting us to sort of start talking about it being in their head or whatever their kind of belief system might be. What we also know about education is that it allows people to understand what is going on in their body, but it also allows people to understand what's not going on in their body. And there's a real sense of relief from that because they come in with huge worries. You know, they're worried about cancers, they're worried about progressive disease, they're worried that, you know, their back's unstable. So learning that the nervous system itself can drive pain is a real sense of relief to people because it validates there is something wrong, but it might not be the thing that they thought was wrong in the first place.
Just a little anecdote.
Yeah.
I mean, it doesn't happen often, but we've had people who, just when they have, say with low back pain, two patients that I can recall, just giving them permission to engage back in exercise or playing with their kids, whatever, because you say to them, look, those X-ray changes, while they show all this disc degeneration, they're no worse than your neighbour who's 50 years old as well, and it's safe to exercise. Just getting that message has flipped people around, you know, instantly. So it's amazing how powerful it can be.
Yeah, and then the last thing I would add is that the education we offer is not just about validation, but there is a group of people who still at the end of our seminars are struggling and they need more than just a one-day education. And what we find with these education seminars and what they've found overseas is that through offering education, which starts in primary care, it actually enhances outcomes 12 months later. So it's not just about validation, it is about enhancing an understanding. If you know what's happening in your body, then it gives you an understanding of what might help to turn it down or to live with it. Okay, so why do we have pain? I don't want to insult anyone's intelligence here. I'm going to be telling you stuff that you already know, okay? We know that you know this stuff, but what we wanted to show you is when we talk about what the education we offer, we wanted to kind of show you what we do, how we explain it. And there might be some metaphors and things that you take from the way we deliver it to patients that might be helpful in your practice. So who knows? Why do we have pain?
Protective mechanism?
Yep. To keep us safe? Yep.
There's a warning system as well?
It's a warning system. It's an alarm system. Yep. So it's an alarm that goes off to keep us safe. Yep. Would anyone add anything to that?
Tells you've done something stupid.
Yeah. Maybe. Or you might be going to. Okay. So it's a useful, if we're thinking about acute pain here for a little bit, we'll come to talk about chronic pain soon. If we're talking about acute pain, it's a useful system in the short term that suggests danger or injury to keep us safe. The alarm goes off, alerting us to danger. We've got here that it's short term, lasting up to 6 to 12 weeks, but we know that with acute pain, it can last a few hours. It could last a few days. You know, if you stub your toe, you don't have acute pain for 6 weeks, hopefully. Most people don't. So it's that acute, helpful alarm system that goes off that most people are born with. And it works in two ways. So think of acute pain as working in two different ways. The first is it alerts us to danger. So if you think about temperature, so we have a threshold that we can tolerate. If it gets too hot, then we can't tolerate it. It starts to damage tissue. If it gets too cold, we can't tolerate it. Walk around in snow for long enough, you'll start to damage tissue, right? So we have this threshold. And what happens is if we breach that threshold, if we go over that or under that, then the alarm goes off to tell you potential danger. And so if you think about if you put your foot into a hot bath and it's too hot, what do? You pull it, it's an automatic reflex. And you reflex so quickly that actually you don't have, ongoing damage to your tissue. The alarm goes off, it keeps us safe. We don't have permanent damage to that tissue. So it alerts us to danger. We don't necessarily have damage at that point. Mechanical pressure, same thing. So we have a threshold we can tolerate. That's mechanical pressure, it doesn't hurt. But if I put my hand in the back of a door and someone closes it, pretty soon I'm going to try and pull my hand out. It's going to start threatening tissue damage, and I'm going to pull my hand out. So we have a threshold of mechanical mechanical pressure that we can tolerate. And the same thing here with chemical release, maybe internal chemicals. Think of something like an ingrown toenail. You get a chemical release that tells you, do something about that toenail. It's starting to cause your tissue damage. It's an alarm that goes off and tells us to react. So usually we can react, and we can react fast enough that we don't have tissue damage. But sometimes we do. So the second way the acute pain system works is to protect us while we heal. So to alert us to danger, type 1. To protect us while we heal, type 2, part 2. So who's been sunburnt? So this guy's been sunburnt. What happens when you're sunburnt and you get in the shower? What's that? It hurts. So what do? How do you cope with it? You have cooler temperature. Your threshold for temperature has changed. You have to have a cooler temperature. Usually you can handle it on really hot, but when you've got sunburn, your tissues are damaged. You've already burnt them once. You have to turn that water down. When you get out of the shower and dry yourself with a towel, you don't just madly dry yourself. You might pat that tissue dry, right? The mechanical pressure threshold has also shifted. And so when it comes to acute pain, we think of it as a warning system, but also a protection system while we heal. And we're assuming here that there's some healing to be done. And with sunburn, there is, right? So next time you wear your sunscreen and you learn. So a system that teaches us something. This guy's got some pretty fancy new shoes, and he's got blisters. So he's not going to be wearing these shoes for a while, or he's going to be protecting that tissue that's been damaged. Once again, if you think about mechanical pressure, that threshold has shifted again. He can no longer tolerate the same amount of pressure on the back of his heel. And then the tissue gradually heals and he returns to normal. He starts wearing those shoes again. And we expect that over time, the course of acute pain looks something like this. So you have an injury, your pain comes on, go and see your GP, and your GP gives you a treatment, and then the pain goes away. Often we don't need to see a doctor. Often if we've got sunburn, it resolves on its own over time. It heals and we return to function. That's the expected course of acute pain. Now the problem is, this is what our patients expect of their chronic pain. So if this is the model that everyone understands and knows about acute pain, is it any wonder that your patients come into you and say, I've got this pain, I need treatment, you need to resolve my pain, you need to do something for me. That's how the pain system works. We're born understanding that. And so expectations about pain start right from when we're really little. I have a 3-year-old and he already asks for things like plasters. It's starting really young. Expectations around pain within our culture, within our family systems, we're born with that. And so what we have to do with people with chronic pain is start to shift that model, shift that understanding of what's really going on with chronic pain and what they should expect.
So I'm not a psychologist, but I always say to people in the room, I know exactly what you want because I've spent time with these guys. And obviously all people in chronic pain, the number one thing they want is for their pain to go away. So we flick it around and we show them these slides. Congenital analgesia, 4 out of 100,000 children are born without the ability to detect any pain due to a little genetic problem of one of their sodium channels. And so she's wearing goggles because in our normal day-to-day course of events, we scratch our eyes and there's no protective function of the cornea, so they go blind. So if they don't wear goggles like that, they get corneal ulcerations and then going blind. They usually remove the teeth. Also, because of chewing and talking, we have feedback of where our teeth and gums and lips are, and so they bite their lips. In third world countries, they don't survive into adolescence. In first world countries, they might survive up to about age 30. Because you can imagine, you get appendicitis, you don't say, "Mum, I've got a sore tummy." You collapse with septicemia, and so they die quickly. Leprosy, bacterial problem with sensory nerves. So just the feedback that we get while we use our hands normally doesn't apply to those people. So a little cut gets neglected, gets some tissue damage. You're not worried about your finger going black and sort of going tall but falls off. So we use this to point out how protective pain is, and that we've evolved with this wonderful alarm sensory system.
I'm the one in the room that gives the patients the warning that some images are coming up that are graphic, and Ian always says they're not graphic. You've seen nothing. You've seen nothing yet. All right. So it's our natural alarm system, and as I've already said, it's a system that we're born with to keep us safe. Well, most of us are born with. This is important. It kind of you can break that alarm down into three components, and John has already started to touch on some of those in his first part of the talk. Pain draws your attention, so it's cognitive, it's a thinking process. It draws your attention to actual or possible danger. Now think about the guy with the nail between his toes. When he looked down, he had that visual input. There was definitely possible danger there. And so first of all, that alarm can be activated by a cognitive process. You've got a visual process, and you've also got a thinking process going on. What do you think he was thinking when he saw that nail? I got a hole in my foot. What else? It's got to hurt.
I'm going to be off work.
Yes. What's my boss going to say? What's my wife going to say? How am I going to pay my mortgage? All of those thoughts are going through his head suddenly. So he's got a cognitive process going on, and he can see that nail through his boot. Pain needs to be unpleasant. It's supposed to be an emotional experience. If it's not, then we're going to walk around with lots of nails in our feet. It's supposed to draw our attention to something dangerous. It has to be unpleasant so that we don't ignore it. We're supposed to get emotional about it. So if you think about that system and how we're wired to get emotional with pain, is it any wonder then that people become more high risk to get things like anxiety and depression and grief and loss-related emotional issues with chronic pain? It's part of that same system, and we'll talk more on that soon. And it's supposed to make you worry, stop, and take action. So it's a behavioural process as well. So it's cognitive, it's emotional, and it's also behavioural. You're going to sit down, you're not just going to look at that nail through your boot and walk around for the day and deal with it later. You're going to stop and do something. So what about chronic pain?
So one of the ways to think about all the problems that we face in pain is that everybody's got the experience of acute pain.
Ian, do you want to just come back behind the microphone?
Everybody's got the experience of acute pain, and if they've never suffered from chronic pain, that's why you get disbelievers and people always reflect back. And it's very different to acute pain. So we've got a time definition which we've gone through. And really the research over the last 10, 15 years is that we've moved away from thinking it's a problem for the majority of people in their peripheral tissues. And so it's more to do with the problem in the nervous system. And the changes that occur have really gone under the umbrella of neuroplasticity. And we know that the nervous system is constantly changing to all sorts of different stimuli. But when I went to medical school, there was this idea that pretty much the nervous system was fixed and it couldn't be altered. But there's been evidence around for a long time that it's more to do with that 1 in 5 that are really upregulating the message and not having the inhibitory messages. And so Clifford Wolff, who was the, he was actually a medical doctor studying physiology in Wald's laboratory in England. And he was the person to really first discover central sensitization, which we'll talk about. And he very much talks about chronic pain being a disease in its own right, because of all the changes that occur in the nervous system and then all the spin-offs that happen to that. But the person who has persistent pain, all pain is produced by the brain, they still perceive that there must be something wrong. So the descriptions of their pain are very graphic in terms of tissues. You know, doctor, my knee's twisting, or it's grating, or and because that's what the brain is actually perceiving, but it's the alarm is now the problem. So one of the ways I like to do it is to really do a diagram of the tissues and then the wiring to the brain, and actually draw a line and sort of say that chronic pain focuses on this side.
And we've got time if you'd like to do that.
I might do it later with the, but it's to really move away from the persistent pursuit of looking for a problem in the actual tissues, which becomes harmful in itself. So you get iatrogenic harm by completely focusing in the wrong direction. Good. Anything else to add?
I guess this is a point that we spend a lot of time on with patients. They come in saying, but I've been told it's a bulging disc, or I've been told it's this, I've been told it's that. And so helping people to understand that maybe there was an event that kicked this off, but once a person's had pain for a long enough duration, and we know that healing will have occurred within that duration, then actually it's less about that event that happened that might have precipitated the pain and more about changes that then happen in the nervous system. And the way I describe it to patients is when that alarm system has been it's turned on for so long that it becomes an automated system. And we use a lovely picture of sheep tracks in our education seminar of, you know, how sheep always follow the same track, the easiest path to follow, and the nervous system's a little bit like that. So once the pain alarm has been turned on for so long, actually it becomes the easiest way, and so it gets turned on if you like. And so moving away from that idea of what might have happened in the first place to becoming a new problem in its own right.
Excellent. Right, so in the previous slides with acute pain, those sunburn pictures or those blisters, when it all goes red, that's peripheral sensitization. So there's physiological changes that take place there so that you lose the threshold. So just now normal stimulus will be perceived as pain, and that's protective. And the same thing is thought to happen it does happen in the central nervous system. And with the population of chronic pain people, you'll see different degrees of it. So somebody can have almost none of these on the one spectrum, and you'll find a group of people that will almost be a full house. And so Eunice, who did a lot of stuff in researching fibromyalgia, came up with the overlap, because you can imagine if your central nervous system is really conveying these electrical messages in a superconducting highway to the brain, then things like fibromyalgia, just simple normal touch becomes painful, and normal movement, widespread pain.
So those thresholds I talked about, they actually move, they change.
The overlap with chronic fatigue is, you all know that, there's at least with people with fibromyalgia, about 30% have chronic fatigue and vice versa. And so that's also thought of in terms of central sensitization. Irritable bowel, where just normal bowel function, normal peristalsis is painful. Tension headaches, just a sensitized system of, the brain with just pain in the head, daily headaches. Migraine, similar thought, where people can just get increased migraines from simple stimuli. Your facial pains, your atypical facial pains, again. So that's the temporomandibular disease problems. MPS, I'm trying to think of MPS.
Myofascial pain.
Oh, myofascial pain. So that's what John talked about. I should know about myofascial pain. No, not always the little acronyms. So your localized pain problems. So some authorities think that that's just a spectrum of fibromyalgia, just in a more localized way. It's a sensitivity problem. So just normal movement of your shoulder now is, really painful. Restless legs, again, motor sensitivity. PLMS.
Periodic leg movement.
Oh, yeah. Okay.
Sleep.
Of sleep, right, yeah. They've thrown the slide at me because normally we've got...
We've got the other one later.
Normally we've got pots there.
Yeah, we've got the other one later.
Multiple chemical sensitivities. So people, you go into the kitchen and your wife just sprayed some cleaning agent and you go ballistic because it's just so overpowering. Menorrhea, primary dysmenorrhea, so, menstrual periods just absolutely over the top and really suffering, and just a normal physiological function is really painful. Now, what's the FUSIC?
Which one?
The FUSIC.
Female urethral syndrome.
Okay.
Interstitial
Right.
John is
cystitis.
also a walking encyclopedia.
You did throw this at me. Yeah, so all your bladder type sensitivity problems, right? And we could probably go vulvodynia as well.
Yeah, there's still more, isn't there, that aren't...
Yeah, so post-traumatic stress disorder, and I think I've got to the end of that.
From a psychological perspective, when we talk about this Venn diagram, and we do, to Ian's credit, we do display it in a different way because this feels very complicated and complex to show patients. So we simplify it. And what we notice in the room is that when we start going around the various different symptoms that can exist with central sensitization, you almost see this relief in the room of people going, oh my goodness, I don't have 4 different problems. I've got one problem, central sensitization, with 4 different symptoms. And what we do from that is we draw from that actually we're talking about a sensitized nervous system that has multiple different ways that it can show up. But we're talking about one management approach that will help all of those different symptoms. So they don't need to be under mental health services and pain management services and whatever other secondary care service. They can actually take one self-management approach that will have benefits for their pain and their fatigue and their mood and whatever, and their irritable bowel, whatever symptoms we're talking about. There really is this kind of in the room when we talk about that, and I think psychologically that's very powerful.
Can I just make another couple of comments about that slide? So, a really important slide. In a tertiary centre, we'd rarely, if ever, get someone who's only got one of those problems. Normally it's a mix and match, it's a combination of them. Yeah. And because it's a common underlying thing. And the way you explain it to patients, like if there's a family history or a personal history of, say, atopy, in the same family, the same individual, different manifestation to the atopy may be asthma or eczema or hay fever or autoimmunity. Maybe type 1 diabetes, Addison's disease, celiac disease, autoimmune thyroiditis. So this one mechanism explains why these things cluster together in the individual and in the family. So it's really important. And the other thing is diagnostically. If you've got someone with 2 or 3 of these lots of symptoms, these are different manifestations of a chronic primary pain. The first slide we looked at, chronic primary pain, can manifest differently in these different ways. Yeah. And
it might be that people at the bottom of that pyramid that I showed earlier who are kind of less affected, they're still the 1 in 5, but they're more functional and they're suffering less. It might be that they have less of these things, or it might be that their management approach is more well developed.
And yeah,
Sorry, just a quick question. So CSS, is that central sensitization syndrome?
Yeah.
Yes,
Yeah.
yes, it is.
And another question is, if one of these got addressed sort of sufficiently early on, does that kind of stop this kind of progression? And if it doesn't get managed well, then it just kind of builds and becomes a big.
Yeah, I mean, it's if they have suitable management strategies, like they're getting good sleep and they're maintaining activities of daily living and they're working and those kinds of things, then there are benefits for all of those symptoms. There's benefits for mood, there's benefits for pain, there's benefits for fatigue. So yeah, I think you could predict that actually.
So if you manage one of them well,
Yeah,
hopefully.
yeah.
well, no,
all
it's
of those
more.
things are protective.
They're protective.
Good sleep,
Yeah.
good
Yeah.
management working, all of those things are protective factors that will prevent the sort of build up of that nervous system upregulation.
Yeah, and of the dysfunction that comes with it.
Yeah.
So when we talk treatments, a lot of our treatments are thought to wind this down.
Okay.
And a lot of our risk factors for chronic pain are thought to wind this up. And we'll elaborate. But the other thing from a GP perspective or practice nurse perspective is that we tend to be very unidimensional in our interactions. So somebody comes in and they say, I've got wrist pain, and then you say, okay, I've got 10 minutes for this. I'm just going to deal with the wrist. If they start talking about chemical sensitivity and peri-pain and bowels, and it just blows your brain out. But when you know this, when you suspect they're a chronic pain patient, you quickly ask them about a few things, or you have a pain diagram, and suddenly it all fits into place, and it's kind of then so much easier. Sorry, question, yeah.
I was just thinking about eating disorders triggering symptoms and being part of that. Because I'm just thinking
We do think that the Western kind of pro-inflammatory diet may have an influence in this, and so that's part of the reason why we advise healthy eating. We'll come to that.
The other part would be a significant life stressor, like developing something like anorexia or bulimia or an eating disorder in that direction. Then that could also be a significant stressor to precipitate some of these other things becoming a problem. Yeah.
Just something else as well. Sorry about that. The other thing that diagram explains, the old thing you've heard, your diagnosis you get depends on which clinician you see. So this person sees a rheumatologist, they'll be diagnosed with fibromyalgia. See a urologist, they'll be diagnosed with interstitial cystitis. See a gastroenterologist, they'll be diagnosed with irritable bowel syndrome. See an infectious diseases physician, they'll be diagnosed with post-infectious chronic fatigue syndrome. But it's the same condition.
No wonder they're confused, right?
Yeah.
Neurologist.
And then we're saying, no, it's central sensitization.
It's quite interesting because you've just summed up the average day for female GP. And it's actually so relieved to hear that there's only one answer.
And that's the relief our patients feel.
Yeah.
That's exactly what I'm talking about.
And that's before you move on to the patient.
The other problem is that they all know they've got these conditions, but they still ask for help.
Yes.
I think that comes back to education again around they know they've got symptoms, but in terms of knowledge of the neurobiology itself, of what's happening in the nervous system, and we'll talk a lot more on that today, and in terms of the management approach, that part's often lacking, and so it's that part we have to look at.